Good evening, everyone. I think people are coming into the webinar right now. We just want to welcome everyone. You may notice a little bit of a different background. Hopefully, it's not too overwhelming for everyone with all the purple tonight. But I'm just so delighted you're here. I am Carrie Howell. I am the CEO for American Migraine Foundation. And I just wanted to start us off tonight and thank you for being here. Thank you for taking the time. I know sometimes people have so many competing priorities on a weeknight, so thank you for joining. And I also just wanted to be here to be present and help you to know that this is sponsored by American Migraine Foundation. And we're so excited to turn this over to Dr. Sando, who is one of our co-chairs of our editorial board. And she is hosting tonight. So Dr. Sando, thank you so much. There's a lot of work that goes in behind the scenes for this, so thank you. And my last push is if you are joining this and you're not part of our webpage or a closed support group on Facebook, please make sure you check out our webpage, check out our Facebook page, which is American Migraine Foundation. And then also we can help lead you to our closed page, which is Move Against Migraine. And we'd love to have you join that as well. It will ask you a few questions, but there's some great responses in there from other patients. And then make sure you check out our website. That's a lot of things to look at once, right? AmericanMigraineFoundation.org. We have our past events, past recordings on the first page, upcoming things happening. But we're just excited you're here. So I'm going to jump off and turn it over to you, Dr. Sando. Thank you both. Thank you all for being here. And thank you to our guest doctors tonight as well. So Dr. Sando, it's all yours.
Thank you, Carrie. Thanks for joining us and kicking off our series. And thank you to our audience as well for being here. So this is continuing our series about women's health. This is the second of a planned 3. And I'm really looking forward to having a conversation today with Drs. Jessica Ailani and Lisa Smirnov. We've called today Family Planning, including pre-pregnancy and infertility IVF. So I will just reintroduce myself for people who may not have joined these before, and then I'll introduce our 2 great speakers for tonight. So I'm Dr. Claire Sando. I'm a headache neurologist at the University of Toronto in Toronto, Canada. As Carrie mentioned, I'm co-chair of AMF's editorial board, and I hope that you are enjoying the content, but please give us your feedback. And just so you know, for the structure of tonight, we're going to have a conversation, and then we'll be taking questions in about the last 15 minutes or so. So please do send those through, and we'll do our best to answer. The following webinar is going to be about menopause. So if you have questions that are more about that, please save them for next webinar, but we look forward to your questions from tonight. So our speakers for today, first, Dr. Jessica Ailani. So she is a headache specialist and director of the Georgetown Headache Center in Washington, D.C. region, as well as current treasurer of the American Headache Society. We're very grateful that she's given us her time tonight. And then Dr. Lisa Smirnov, who is an assistant professor of clinical neurology and is board certified in both neurology and headache medicine at the University of Miami Miller School of Medicine. And these people, I think, are both great experts on the topic that you're about to hear us chat about. And I'm looking forward to their expertise. So we are just going to kick things off by having a bit of a look into what migraine does in terms of impacting family planning. And so Dr. Ailani, maybe you could start us off by just your thoughts on what you've heard from your patients and what you see. How does migraine impact this for a woman?
Yeah, so I think it's important to start by realizing that unlike many disorders that people come to see the doctor for, migraine is one of those things that is very predominant, so really common in women, and unfortunately is almost double seen in women compared to men. So I think of it almost as a women's health problem. And when you're coming to a headache clinic, you'll notice in the waiting room, almost half the patients are women. And, it's kind of a nice environment in that way. It's a lot of different women to talk to and different paths of their life. And so when you're in that type of clinic environment, we're really taking care of a woman from maybe when she's finishing up college or finishing up school, going all the way through her career path, when she's getting married or in a partnership, and then thinking and planning out a family, all the way through her kids going off to school, and then thinking about menopause and retirement. It's really quite an amazing situation on the clinical side. As a physician, it's one of the most rewarding experiences to see that. But it's also extremely difficult because you're seeing this disease that's affecting a woman through all these major life points. And I think in a time period where we've come so far as women and we're in the workforce and we're really progressing and ending up with larger positions, this type of disease really slows us down. We see patients not taking promotions, not being the boss, deciding not to have children or delaying that decision because they're not doing very well. And they're worried about things like, what if I do have children? Is this going to be passed on? Am I going to be the reason that someone else is going to be really disabled from this kind of disease? I'm pretty healthy. I don't have any other issues, but here I am, a few days a month, really struggling to get up, to do things, taking medication and feeling like it's really tough to get through my day or several days because of this. And I'm not sure I want to pass that on to someone else. And so having these types of conversations with women, it's a really big part of what we do day to day.
I really like what you said, and I've found one of the rewarding things in my own practice, getting to follow people through thinking about the first pregnancy and then through breastfeeding, and then thinking about the second, and just having seeing their life grow and blossom, hopefully with the kinds of migraine treatments that we have to suggest. Do you notice that in addition to being concerned about passing down migraine to children, which you mentioned, that women are worried about the impact of pregnancy itself on migraine and their treatments as well?
Yeah, I think this is another really important point to bring up. I mentioned that many people will consider not having children, and we have studies that show up to 30% of women decide not to have children because of the impact of the disease itself. Sometimes you'll be taking care of someone and they start to do really well, and they're really excited. They say, I've had many patients who start to do well under treatment, and they're at a different point in their life, and they say, well, Dr. Lonnie, I feel really good. My migraines are under control. I feel really, really well managed. I actually think I now want to have children, where I thought I could never do this. And it's very difficult because there are a couple of things I think people don't realize. On the healthcare side, we always understand that when you're thinking about pregnancy, the first thing we want to do is we want our patients to be on the least amount of treatments possible, just so there's a healthy environment for the baby to grow. But I often realize patients don't understand or realize that. And so the first part of the conversation is this misconception of, I can take everything I'm taking right now and it'll be just fine. It's that first initial conversation of, this is really wonderful. I'm really excited for you. Let's have a conversation of how we might need to make some changes, how long that period might be of making these changes, coming off your treatments. And I am going to be here for you. You probably will do okay, but there might be a struggle during a small period of time when you're coming off medications, when you're trying to get pregnant, and then that first trimester of pregnancy. I think another big misconception is that people tend to think once you get pregnant, it's all going to be great. Everybody says nobody has migraines anymore in pregnancy. And I think the trouble with that is you can continue to have migraine attacks in pregnancy, especially the first trimester, when you have higher levels of one of the hormones called progesterone and lower levels of estrogen. And we think this might correlate with sometimes people having more frequent attacks. And also you're tired, you can be really sick, you might not be eating very much. And all of this can also correlate with more frequent attacks. If you're tired, but you're not sleeping, you're still trying to work, you're pushing yourself, you think you're a super person and you're going to have that great pregnancy like your best friend did, and you're only going to eat vegetables, because we see this all the time. The need to, have the kind of pregnancy that everybody on social media is having, and putting yourself through that stress and do everything like you used to do. And then you're not capable of that because maybe the pregnancy is difficult and maybe you're really sick and maybe this isn't being addressed. And so, having these conversations about it can be really tough. It's important to eat if you can, but if you can't, what other things can we do to help you through this time period? What are your options for nausea? Because if there's nausea, there's no nutrition, migraine will get worse. And so we got to work through all of this as well. So I think it's a lot of conversation, and that conversation is extremely important to have earlier rather than later. But it shouldn't be done with oh, no, this is just not possible. You're just doing better. So no, you can't get pregnant. Instead, it should be like, I'm so excited that you're feeling this good. So let's talk about how we can walk through these steps and what that might look like. And how do you feel about this process? And what are the different options that are available for the different stages of pregnancy to treat if you're not feeling well, and when things might start to look better in pregnancy, and kind of walking through that process as well.
Yes, absolutely. Trying to align on goals and have that open conversation is really important. And just a plug for the AMF Find a Doctor tool. If anybody who's watching our webinar doesn't currently have a headache specialist that they feel they have the kind of relationship with, that tool can be helpful to help you find someone that you can connect with. And I do want to highlight, we had another webinar in the fall on some number of details about treatment in pregnancy that will be available on our events page soon. We're going to talk about some of those things tonight, but if there are still some questions there, that webinar will hopefully help answer them. Maybe, Dr. Alani, one last question before we talk about some of those specific treatments. What do you tell people about the likelihood of them passing migraine on to their children?
So there's a chance, not a guarantee, but there's a chance that if you have migraine, your child might have migraine as well. And the chance is even higher if you and your partner have migraine, that the child will have migraine as well. And that's a genetic link. Migraine does tend to be a genetic disorder that gets passed down in your genes, just like the color of your hair, the color of your skin, the color of your eyes, and other medical disorders you can have, like high blood pressure or high cholesterol. My favorite comment from today I had was a patient of mine who has diabetes and eats healthy and does everything right, but it's a family thing, runs in the family. And I often stress to patients as well, migraine is like that too. You can do everything right, but if it runs in the family and it's genetic, it's just something that can get passed down. So our studies show us that it's anywhere between 30 to 50% chance that the child genetically can end up having migraine. But when we look at families, one sibling might have it, another sibling might not. And I often notice it's not like if your migraine is like X, that child's migraine will be like X. They can be very different. They can be less severe, more severe. The one thing that tends to track is if you have visual aura, the child might have visual aura as well. There's been studies looking at certain genetic links between certain types of aura that can run in families. But again, nothing can really be a guarantee.
And we're doing our best to get to people with migraine sooner and help them find care and do better and stay better over their lifetime. So this may also be a difference for people whose children are born with migraine. So maybe we'll switch gears a little bit and talk with you, Dr. Smirnoff, a bit about what to tell people about how to prepare for pregnancy. What are those kinds of changes that can and should be made for, maybe to start with the lifestyle?
Great. Yeah. So similarly to how you might prepare for your pregnancy by starting pregnancy prenatal vitamin, there's certain things that you can do to actually help with your headaches too. So I think one of the things that can impact migraine a lot is stress. So anything that can help you with stress management is going to make a huge impact. There's studies that have looked at yoga, meditation, mindfulness. There's a lot of different resources where you can get started with this, but keeping a consistent practice in any of those can help with reducing your overall stress levels and can overall impact your migraine too. If there's other things that coming into the pregnancy that may impact your migraine, those are important things to consider. For example, if you're feeling anxious or if you're feeling depressed, this is a great time to see a psychologist or a psychiatrist to really have that great foundation before you're leading into that pregnancy period. The same way that physical therapy can play a role. So I love for a lot of my patients who are planning to become pregnant to have a physical therapy evaluation if they're having any neck pain, if they're having any shoulder pain, because not only is it going to be helpful for those mechanics while your body is changing and adjusting, but it's also going to be helpful when the baby is born and when you're already carrying around extra weight of the baby themselves. So there's all of those things can make a huge difference. Now, on the more specific side, your diet can also play a role in migraine. So a lot of times, I think I don't like to encourage a very strict elimination diet. I think a lot of the elimination diets can add additional stress and they can remove the things that you really like from your diet, but keeping a regular and consistent diet has been shown to be effective for migraine. So keeping your meal times the same, keeping a healthy diet. For the Mediterranean diet in particular has been shown to be helpful for migraine. And sleep. Consistency is really key. So when we think about sleep, it's not that you have to sleep exactly what the hours that society recommends, but it's more so keeping consistent sleep habits. So that can mean, waking up at 9 o'clock or 10 o'clock if you're a night owl, or it can mean waking up at 6 or 7 if you're an early bird. So that can be helpful. And particularly if you're thinking that you have difficulty with sleep, this is a really great time to look into sleep therapy. There's actually sleep therapists who can help you develop a sleep schedule that can really affect your own needs. So whether you feel like you're having difficulty falling asleep or staying asleep, they can help you develop those healthy sleeping habits, such as maybe not using devices before bed, keeping a consistent wake up time. All of those things can help. And additionally to that, non-medication options can help too. So if you're thinking about how am I going to transition to pregnancy where maybe the preventive medication that I'm on for migraine is not effective or maybe is not safe, that's when you can consider all of these non-medication options. So this is where acupuncture, biofeedback, and neuromodulation devices can play a huge role in your care.
Thank you. That was a lovely overview of a number of really great strategies that I think have a huge impact for many of my patients who try them. I do just want to also highlight that it's sometimes difficult for people to hear work on stress, work on sleep. That can make people feel like it is their fault, that they're doing something if they're not doing really well. And I don't think that's what we as headache specialists think at all. We think that people who have migraines are born with migraines, and then all of these things can add up to make it worse. And so these are all the things that you may have control over that may try to reduce the sensitivity of your migraine pathways. You still have migraine, but these are all the really great non-medication options to help set you up for success in pregnancy. And hopefully aligning with patients on that helps people feel supported rather than told it's their fault, which we would never want people to feel. And you touched a little bit on the idea that some of our medications are not as safe for pregnancy. Obviously, this is a huge topic, and we're not going to be able to cover the entirety of it tonight, but maybe it'd be worth touching on just a couple of specific things because there's a lot of buzz, in particular around some of our newer treatments. What do you tend to tell people about their approach to their preventive medications when they're planning pregnancy?
And first of all, Dr. Sando, thank you for adding that point. I think a lot of our stress management and sleep management goals are all very idealistic. A lot of times I work with my patients on what's possible. So we set up, the 5 things that maybe would help their migraine overall and like, what is the one thing that you can work on right now? And I think that helps the most because none of us are going to be able to have the perfect sleep schedule or, the perfect meal schedule all the time. Like, I have migraine and I've definitely skipped lunch. So I think it's also really important to be kind with yourself in that process. In terms of medications, so I will note that a lot of women will get better during their pregnancy. So there are a number of women who will actually not need to continue their preventive medications or who may be able to reduce their preventive medications during pregnancy, which I think helps a lot. It helps with the pregnancy itself, and then it also helps with the developing baby. There are certain medications that are absolutely not allowed in pregnancy. So, for example, medications like valproate and topiramate, candesartan. At this point, CGRPs are not recommended in pregnancy. There have been some studies linking CGRPs with preeclampsia in animals. So at this point, we don't think that they're safe in pregnancy. But again, this is very early information. So I think that we're going to have to see a lot more information on this. There are medications which are considered to be safe. So for example, some of our migraine vitamins like magnesium and riboflavin are considered to be safe most of the time. Of course, it's important to discuss with your OBGYN for what they consider safe. In terms of our abortive treatments, medications like triptans and acetaminophen are still considered safe during most of the pregnancy. Now, there's a whole other discussion that could be had around neuromodulation and devices, but we do have multiple devices on the market now that can actually be really helpful for migraine, which, could potentially provide another safe and more efficacious option. Botox and occipital nerve blocks, there's a lot of discussion ongoing about whether some of these things are safe or not. But I think that this is where having a headache specialist, especially if you have chronic migraine, is going to make a huge impact in helping with your care during pregnancy.
Which is a great segue to my next question for Dr. Ilani. If you had all the time and resources in ideal world, what kind of team would you want to put together for your patient who was thinking about trying to get pregnant?
So for all my patients that are trying to get pregnant, I mean, clearly we're on their team. And actually, I think for a good portion of it in the beginning, we're seeing them quite frequently. We do manage a lot of the discussions about pregnancy planning. I think that's because it's a big interest. We're an all-women group, so we have a very high interest in just discussions about menstrual planning and ovulation and what does this all mean, going back to high school and then college and medical school. For some of us, the idea of like, oh gosh, here we are drawing out a menstrual cycle and talking about where you are ovulating and what does ovulation mean. But the reason we do this is because very early in my clinical practice, I came to realize that many of our patients actually did not understand any of this, and we're seeing their neurologists having these discussions about coming off medications and then just being told, okay, go get pregnant. And they didn't understand it's not just so simple to just get pregnant, especially if you're someone under a lot of stress who has a disease and maybe are in your 30s. And then some of our patients now are in their late 30s, early 40s trying to get pregnant. And if they don't understand how to advocate for themselves, understand how your menstrual cycle works and in what part of the cycle you can get pregnant and you probably might not get pregnant, how to check for ovulation, when to actually have intercourse, and when to start to have conversations with a specialist with fertility issues, and how maybe you don't have to wait 1 year if you're under 35 because you actually have a pretty significant health disorder like chronic migraine. And waiting a year trying to get pregnant and struggling through this when you're having frequent attacks is just don't think that's really okay. And it's been very impressive to me as we've taken this approach, how often we've been able to get patients into fertility treatment and have them discover there actually is a problem. And to me, that's actually made a very big impact in how we practice. So we're a big part of their team. The second part of the team, I think, is anyone who has any question about safety of treatment is getting them a maternal fetal medicine consult. If there's certain medications they need to stay on and they're not comfortable with the conversation we're having, or we're feeling like maybe they're not quite understanding what we're saying, or they're not comfortable with what we're talking about, that MFM consult is extremely important. If we feel they have some medical conditions that might increase their comorbidities and potentially need to have that consideration of being on aspirin for preeclampsia risk during pregnancy, we're shuttling them to MFM. And we have actually a great group that works with us and is extremely supportive to our patients and have taught us a lot about what our migraine patients should be on. So they're a great group for us to be working with. And then fertility specialist. I think that's extremely important to have supportive fertility specialist team, because like I said, if a person is really struggling getting pregnant and is having frequent migraine attacks, I'm talking about 15 days or more a month, I mean 3 months of not being on a lot of treatments for that person, it's not easily livable. And so for that person to be told, wait a year before you can talk about how we can help you through this, is not something I like to hear for them. So having a team that's willing to talk them through options and really sit through and talk about, let's look at your ovulation chart, let's check your temperatures, let's see if there really is a problem, and not wait that full 6 months to 1 year, I think is very important as well. That's my ideal team.
It's a great team, and it's especially tough when people are trying and it's absolutely not clear how long it will take a given person to get pregnant. So having the support during that time, no matter how long it is, hopefully not too long, is really crucial. Okay, and I also really like that you highlighted some of the other things, because we know that many of our patients with migraine also have other things, like often mood issues that need to be treated well as well. And so it's not necessarily the case that people can just stop everything and get pregnant, like you said. So, okay, so we'll try to get the team on our side, and maybe we'll shift it over to Dr. Smirnoff again and talk a little bit about what happens to our patients who do end up needing fertility support to get pregnant. and how that impacts migraine itself. What can we tell our patients?
So that's a really great segue, and I appreciate what Dr. Ilani spoke about, kind of getting yourself a great team, because I think that makes a huge impact. I often work with our reproductive endocrinologist to kind of try to figure out if there's anything that we can do on our side to sort of make the process easier, especially for our patients who may be, trying to conceive for months or years at a time. And so when we think about fertility treatment, a lot of times patients are getting estrogen or progesterone analogs, or they're getting medications that stimulate those hormones in our body. And so there can be pretty significant hormonal shifts. And while for some patients, this can be great. Like I've had patients who have migraine who, once they start their fertility treatment, feel great. And so it's not necessarily a thing that you should be afraid of. I think that this is always a discussion with our patients. But there are going to be patients who will feel worse, particularly when they're having, their estrogen levels go up high and then drop. And so that's oftentimes an area where I'd like to have some strategy for what to do. And so similarly to the way that we treat menstrual migraine, maybe with some situational preventive, or maybe with an abortive strategy that works around that short period of time, it can be really helpful for us to have a strategy for when they're coming off of their fertility treatment, or when there's a transition that maybe has made them feel worse in the past. So I think that that would be the most important piece, is kind of working with your headache specialist to see if there's medications that you can take during the fertility treatment that are actually going to sort of reduce the impact of it.
And I absolutely agree. It's very tough to know for the individual person sitting in front of you how their journey will go with fertility treatment. Do you have a general sense of what you can tell patients? Are more people likely to feel unwell from a migraine perspective during fertility treatment? Are more people likely to do okay?
I think from my experience and from the studies that have been done so far, typically people may feel worse, especially during IVF treatment, where you're using the injectable medications that cause pretty significant elevations in your hormones. You can have some worsening either towards the end there or right after those medications are stopped. I have had patients who've gone into like worse cycles of their migraine right after, or they've had some worsening around times when a medicine called letrozole, which suppresses hormones, actually is used. So those things sort of can flare up migraine. That said, I also have had patients who have done really well. So I think it's always an important thing to work together and really advocate with both your fertility specialist and with your headache specialist or your neurologist that you may have these specific needs during the cycle. The other piece that I would really encourage is communicating those needs with your fertility team. So I think a lot of times by the time that I get a referral from the fertility team, it may be already like a few cycles in, where the person has had a really hard time for the first couple of cycles of IVF, for example, where they've had much worsening in their migraine. And so I think it's important to tell your fertility team up front, I have chronic migraine. This is an impactful thing in my life, and it would be really important to get care early on. And it's not something that's going to prevent you from having fertility treatment. It's going to actually improve your treatment overall. Now, with that, I think it's also important to note that telling your fertility team about migraine is important, because women with migraine with aura have a very slightly increased risk of stroke with estrogen. And so if you're getting estrogen containing products, some of the fertility specialists will actually consider giving you aspirin during your whole fertility treatment. And so there can be modifications in the fertility treatment that actually address that.
Yeah, and that's a really tough one when somebody really would like to be pregnant and there are those safety concerns. How do you navigate those questions? Because I get these consults sometimes from the other side being, is it safe for the estrogen kind of regimen that I'd like to use for this patient for fertility? How do you help the fertility team navigate that aspect? What's safe and not safe in people who have migraine?
I think that's a really challenging piece. In my perfect world, if there are protocols that maybe reduce estrogen in especially women who have, complex aura with their migraine, like if you have basilar migraine where you're having any weakness or numbness in your body, then particularly in those patients, I would want to see a protocol that maybe reduced estrogen containing products. But if that's not possible, I think it's working with the team to see what else we can do to reduce the stroke risk. So that's where medications like aspirin and sometimes even anticoagulant medications can come into play.
And Dr. Ailani, what's your approach to this? I think this is a tricky thing because we want to support our patients' pregnancy goals and we also want to keep them safe.
I think the trouble here is the complete lack of data. I wish we actually had information because we can do like what Dr. Smirnoff is talking about. We can do all these things. We can put them on aspirin. We can give them anticoagulants, but we actually have no data to say that this is going to protect the patient at all. I'm honest with the patients that actually have no idea, but I don't want them to stop treatment to not get pregnant because of a potential small risk. I will say in the 16 years of practice, I haven't seen a negative outcome in this patient population. That doesn't mean it won't happen. It just, I think that one thing I've seen over time, and this is the amazing thing about medicine, is how fertility treatment has become a lot more flexible. And it used to be there was like 2 drugs they used, and that was it. You had 2 drugs, there were 2 doses. I could tell you exactly what you were going to get and exactly how every patient would respond. I don't see that anymore at all. I found that if, in fact, like you were saying, if a patient goes in and is very clear that they have migraine, that these doctors are already making adjustments to the plan in advance. And by the time my patient has come in to see me, they'll tell me, and these are my established patients will tell me, actually, I'm doing pretty well. I told the doctor in advance. They made adjustments in advance. I'm on, and they're all on different treatments. I never end up with 2 patients on the same type of hormones. So I'm impressed with the changes but you're right, there's not a particular protocol. Every place they go might do something different, but I do appreciate that changes are being made. I do think this is an area we really need to focus some data, because I would love to be able to say, I know that if we put our patients on this, or this, we're bringing their stroke risk down by this percent. Even 10 or 15%, I think, is something. It's just worrisome to me because I don't want to tell a patient, this is going to protect you, and we have no idea. I do think, though, this is what we like to do. We try to offer the best we can with the hope that we're doing something positive. And I actually think a baby aspirin is not a bad idea in many of our patients with migraine in general in pregnancy, because it itself is a risk factor. I am not advising anyone listening tonight start a baby aspirin without talking to their OB about doing that in pregnancy as well, because there are many other factors and you shouldn't take it in your first trimester. And there's a lot about that. But what we're really trying to discuss here, it is very complex and there's been a lot of changes. And our hope that there's a lot more data so we can give better information.
Absolutely agree. We need lots of research. And the other thing that I wonder about, just also with the fertility treatment piece and migraine, I wonder if either of you have experience with this, is ovarian hyperstimulation syndrome. Do you have a sense of if there is risk with people who have migraine for this and how that plays out with migraine attacks?
Oh, that's such an interesting question. I have looked into this and I haven't seen a particular relationship between migraine and ovarian hyperstimulation syndrome. But what I would suggest, or what I would imagine, is that if you're having ovarian hyperstimulation syndrome, which is something that can happen in IVF treatment, particular, where the ovaries can swell and become overly productive with many follicles, can be quite a painful syndrome and actually cause a lot of discomfort and also swelling. So in terms of that, I wouldn't expect it to necessarily affect migraine. But obviously, the person may be feeling poorly overall. So if they're dehydrated and feeling sick, that may, in effect, actually cause their migraines to worsen.
Dr. Lani, is that something that you've seen at all? I have the impression that some of my patients have had pretty bad migraine attacks during this, but again, I don't think that we have data here. I think that we need some studies as one of those rapid hormone changes.
I haven't seen it, but I agree. This would be interesting. And if you've seen it, maybe you should write some of these cases up because it would be interesting to see. And then I also think the region I'm in, many of my patients tend to be a little bit older when they're getting pregnant. And I wonder if that's less likely to happen when you're in your 40s. It's just not as likely than when you're a little bit younger and doing IVF. Or maybe it's just not something I've asked enough about to figure out if that's something that's happening.
That is also to your point about sometimes people will come to you after they've done several cycles. They've already got a protocol in place with their team. I wonder if patients are not necessarily discussing this with their headache doctors. If anybody listening has this experience, please share it on our Move Against Migraine Facebook page and let us know so that we can help keep learning about the impact of fertility and migraine and how best to treat that. And just that also made me think about some of the other things that our patients with migraine can have. And so we're starting to learn a little bit more about the links with migraine and some other health conditions, such as endometriosis. Is that something that you have seen with impact on migraine and fertility journeys?
So there's definitely seems to be a relationship between migraine and endometriosis. Women with endometriosis in particular are much more likely to develop migraine, and women with migraine have somewhat increased risk of endometriosis as well. I think it's about 2 times as much. So in terms of the relationship, it's definitely there. Some of the things that have been seen to play a role are prolactin, which is a hormone that can be produced not just by the pituitary gland in the brain, but actually by some of the endometriosis tissue as well. There's also a relationship between estrogen and migraine. So potentially some of the other hormones that are being produced during endometriosis can impact migraine as well. The other interesting piece there, obviously, is that endometriosis is a common condition that can cause infertility. And so when we see somebody who may have both conditions, it's interesting to see what may affect both. There's some very, very early and sort of non-specific data on that's leading to the potential that CGRPs may have an impact on endometriosis. So potentially some of our treatments for migraine may actually have some downstream effects on the endometriosis as well.
And, I think this is an area that actually actively is being studied within the field of migraine. So it's going to be really interesting to see the literature start to grow. I think that as we have more women headache specialists and women researchers, it's definitely an area that many have picked up as an area of interest, something that comes up. And it used to be something, again, when I was younger as a clinician, you just, in one ear, out the other, you're like, okay, great. But it's something now you're starting to realize that the more uncontrolled endometriosis is, it's very common to see that correlation with their migraine disease burden being more severe. And there's some literature that suggests that not only with endometriosis, if there's associated adenomyosis, that migraine can be much worse. And I had a clinical patient that had this situation and her OB was like, they're not related. I'm like, they are definitely related. And they were suggesting surgery. I'm like, get the surgery done. You're going to see a huge impact in your migraine. It's going to get reduce. And lo and behold, after surgery, she was feeling much better. And she's like, you're the only one who said that to me. Is that because we see it a lot? And I'm not surprised OB doesn't realize that correlation because they're not talking about the headache where we're talking about headache associated symptoms, periods, and all of it. So this is what we're seeing every day. And so it's nice to start to see more literature and then bring that focus back where we used to maybe not pay attention as much. And now we're like, let's talk a little bit more about this. And then let's double down on what hormones you're on and loop back to this idea that there might be a connection that's important to focus on.
This is also to the point about getting that really good team talking to each other on your side when you're doing all these treatments, so that we can try to help manage all of these different aspects, whether it's the infertility or the migraine attacks, or whichever piece is most bothersome. And okay, and maybe we have just a couple more minutes before we're going to stop and take some questions. Just to touch again on one of the other things that we've talked about briefly. Is there ever a time when you would tell someone with migraine you didn't think it was safe for them to have fertility treatments?
That's a really good question. I think as somebody who's just very optimistic, I would like to say no. I think that there's situations where maybe your migraines are significantly worse. You're on multiple medications that are not safe in pregnancy, but are potentially improving the migraine. And if you have significant disability, I would maybe discuss, is this a good time or should there be a delay? The other, discussion that Dr. Ilani pointed out is that we really don't know a lot about the safety. So, for example, in patients with hemiplegic migraine, we don't really know if it's safe to give them estrogen or not. I think this has to be a discussion with both the patient and with the fertility team, but I wouldn't put an absolute no for anyone.
Yeah, I agree with that. I think it's a conversation, and your job is to present the information in a caring manner, just like, this is what we know, this is what we don't know, and you're here to support them. I think it is important, though, that, especially the patient who's really struggling with their disease burden. I sometimes see a situation where the person wants a child but is worried about managing the situation, like taking care of the child, doesn't feel like they have support, is getting spousal pressure to have a child, that you open dialogue about, well, let's talk about a couple of things. There's surrogacy, there's adoption. What support do you have in the house? Before you think about the child, like, how about we talk about what support can you get into the house? Can you hire help? Can you have that conversation with the spouse? And I think sometimes you're that only advocate that the person might have to open up that dialogue and have the conversation. And sometimes I've been able to provide that, we have a chat and we give them some pointers to the person to be like, but I'm going to take this home and have that conversation and then come back. And again, I've seen my patients through surrogacies. I've seen them through adoptions. I've seen them through like working out a situation where they had that conversation with the spouse and said, I'm going to wait about pregnancy until we set up better childcare at home, because right now I cannot manage with the one child and this disease. And again, I think it's that whole situation of being there for the person you're taking care of. And again, this, when I talk to other healthcare providers, they're like, oh, that seems like it takes so much time. I'm like, it really doesn't. These are very short conversations, and they're so important to providing that aspect of care for someone with migraine who maybe has someone in their family that doesn't understand the burden of disease. And I think it's just really, really important to be that help and that advocate for them, to be like, I'm here to support you. If it's not medication or devices, or sometimes it's just, what's the plan going to be on the other end? Because when the baby comes, there might be a period of time you're not going to be on medications. You might be doing well with migraine attacks, but you won't be sleeping. Are you going to be okay? Like, what's the plan going to be? Let's talk through this whole plan. Let's figure this out. So I think that's just as important as safety of treatment that they might be on. And I think that's another way we can be supportive.
Those are all great ideas. And I love that they're also working against some of the stigma about, you'll probably be fine, it's just migraine. That is absolutely not helpful to people who are living with migraine and living with all of these symptoms on a regular basis. So thank you both for the really thoughtful ideas and comments there. We're going to turn it over to some questions, and just to note to our audience, please do keep your questions coming. We're going to do our best to answer as many of them as we can. So here is one to start. So how do you manage when you're not on prevention? Somebody is saying that their OB team suggested they be completely off their preventives for 3 months before trying to conceive. We're talking oral preventives, and they're not feeling well. What to do in the meantime?
So I mean, it depends on the preventive medication that you're taking. I just want to start there. We don't necessarily recommend that you're off preventive treatment for 3 months. It really depends on, I'm going to try to put this in easy terms, how long the medicine is in your system. The rule is it has to be out of your system 5.5 times of the half of the amount the medicine's in. That seems really complicated. We do the math. For most medicines that you take by mouth, that can be a few days to 2 weeks. So 3 months is a really long time to be off your medications before you start trying for pregnancy, if it's a pill you take every day. So I just want to start with that. Things you can do if you're having difficulties. I think we talked a little bit about, lifestyle changes, behavioral modification, neuromodulation devices. These are great ways to start. If that's not helpful, peripheral nerve blocks like a greater occipital nerve block. These have been studied and can be helpful to help kind of settle the attacks down while you're trying for pregnancy. And in our clinical practice, if it's approved by insurance, we'll have a patient come in monthly for blocks just during this time period while they're trying for pregnancy to just get things settled and keep it calm during that time period when they're trying for pregnancy. Then it depends, which type of migraine, if it's episodic or chronic. Someone with chronic migraine in our practice will continue with onabotulinum toxin or Botox during that time period. Because again, we have a great MFM team that supports the continued use of Botox through pregnancy. And so our patients can continue that, but that's only if you have chronic migraine. It's not approved for episodic migraine. So these are some of the options our patients have to go through during that time period.
The other
I think one of the I was just going to say, I think one of the things that what you said, Dr. Ailani, made me think is that that person might benefit from having a headache specialist advocating on their behalf as well. Dr. Smirnov?
That's kind of exactly what I was going to add, because I think this is a tricky situation because you want to be able to follow the directions of your OB team, but sometimes it's difficult to maybe get across what your needs may be in terms of the migraine. And so that's where I think working with a headache specialist or a neurologist who's really able to advocate for you can be really helpful, especially if they're in the same system and the two doctors are able to communicate.
And there was, in fact, a question about onabotulinum toxin in pregnancy and how people do if they continue in pregnancy. Any thoughts about outcome?
So at this point, as far as we know, onabotulinum toxin does not cross the placental barrier. So even though we're doing injections peripherally, potentially the concern may be, is it circulating through my bloodstream? But as far as we know, it does not cross the placental barrier. So many providers will feel comfortable continuing onabotulinum toxin during pregnancy. I think this varies a lot with provider to provider. So that, again, I think is finding the right provider who may be willing to continue it for you if that's an important part of your treatment plan.
It's also
outcomes. Go ahead. I was just going to say outcomes wise, there's some data out there that's published past the first trimester, looking at outcomes. How does the baby do? And so far, there hasn't been anything published suggesting that there's any trouble with the baby. There's no trouble after when they're born. We have a registry in our clinical practice looking at pregnancy and outcomes. Majority of the patients are on onabotulinum toxin or Botox, and there has not been any negative pregnancy outcomes from Botox itself. So I think, like Dr. Smirnoff was saying, that and it's so hard. I just want to call everyone by their first names. But it really is about finding someone who's comfortable doing it in pregnancy.
And it's also true that not every patient is going to feel comfortable with this. Some people will hear this and say, great. And some people hear this and say, I heard you say there's no long-term safety data. I don't feel comfortable. And that's fine to have a difference of how you feel about the options that are presented. When your patients are staying on onabotulinum toxin in pregnancy, do they tend to stay on it the whole time? Do they stop? Do they get better?
We let our patients know, it's up to them. It's really funny though to me that, well, so this is what I've tended to notice. First pregnancy, what someone does, and all the other pregnancies after are very different. First pregnancy, and I've had 2 children. I can tell you I was the same way. My first pregnancy, I stopped caffeine and my anti-allergy medications. I took nothing and I was miserable the whole time. Second baby, I had a cup of coffee every day, left my allergy medicines on. And I think this is the natural way of things. We get a little bit more comfortable the more times you've been pregnant. So I often think our women who are pregnant the first time are hesitant. They might stop on their Botox treatments before, see how they do, might struggle and then start back up, might stop then in the second trimester when they're doing a little bit better. I've had other patients, just struggling the whole time. And so they'll continue throughout. And then whatever they do the first pregnancy, they tend to do something different the second time around where they're like, I'm not doing that again. Just keep going. Even if I'm feeling better, I don't want to stop. And I was like, are you sure you're doing great? Like, you're probably going to keep doing great all the way through lactation. Like last time, they're like, no, don't stop. Don't stop because I don't want to take a chance and I have to be there for my children. And so we respect what the patient feels at that time, though probably they would be fine without it. It's more that fear of if I stop and I get worse, what's going to happen? And I can understand that.
Absolutely. Okay, so some varied questions that we've got here. There is a question about the impact of migraine attacks themselves when you're pregnant. Does this harm the baby if they are frequent or severe? For example, this person is mentioning what sounds like probably violent vomiting. Is this harmful to the baby if somebody's having those bad migraine attacks while they're pregnant?
So, I tend to tell my patients, migraine is not a benign problem. If you're having attacks and you're laying down and not moving around for 1 to 2 days, you're not eating or drinking anything and you're throwing up, it's not the best thing for the baby. And if this is happening multiple times over and over again, we have data that shows us that people with migraine are more likely to have preterm labor, smaller babies. And then there's a suggestion that migraine also might cause preeclampsia or higher blood pressure through pregnancy. So migraine can be harmful in pregnancy itself. So that's why I tell my patients, don't ignore, you should treat, because that baby is being harmed every time that you're not well and you're not eating and you're not moving. It's not great for the baby itself. And I have never had an OB argue that point. If you tell your OB you're throwing up and you're not moving and you're not eating, and this is happening several days in a row, they actually will be the first to prescribe treatment for the patient because of the amount of data out there, but that lack of movement and the disease impact on outcomes for pregnancy.
We have a question that I'm going to give to Dr. Smirnov. Do you, so far as you know, think the evidence is showing that migraine causes endometriosis, endometriosis causes migraine? Is this just a correlation?
So there's an interesting study that actually showed that potentially women with endometriosis are more likely to develop migraine. So I don't think it's necessarily bi-directional where endometriosis and migraine can cause each other, but there does seem to be some foundation in that maybe women with endometriosis are more likely to develop migraine.
And there are a number of questions about specific treatments during pregnancy. We're going to try to do a couple of those. I would also direct people to the dedicated pregnancy webinar we ran back in October. The recording from that should be up on our events page in the not too distant future. That's americanmigrainefoundation.org/events, where the recordings, including from today, will be posted, that everyone is welcome to watch at their leisure as well. So there is a question about which kinds of devices we tend to think of as potentially to use during fertility treatment and or pregnancy.
The one device that actually has data in pregnancy, which I find just impressive that anyone studies anything in pregnancy, it's not that simple, is the REN device that sits on the arm and just for the sake of our audience, I'm going to use the brand name. It's the Nerivio device. And that was a device that it can be used as needed for migraine, but also every other day as a preventive treatment. They studied 16 or so patients in pregnancy through the entire time of pregnancy. Again, very rare, not only to study patients who are pregnant, but through all 3 trimesters. They usually stop studies after the first trimester. And they compared them to non-pregnant women, and it was just as effective, and there were no negative fetal outcomes. So I think that gives us some safety data. But we do, I mean, there's many other devices. And Dr. Smirnoff, if you want to mention what devices that you frequently will prescribe or offer to your patients during pregnancy.
Yeah, our group recently actually looked at a review of neuromodulation specifically in pregnancy. And so even though we don't have data specifically on some of the devices themselves, there is data that correlates well with some of the devices. For example, the vagal nerve stimulator, which is called GammaCore by its product name, there's actually data of vagal nerve stimulators that are implanted for women with who are pregnant. So we think that probably based on that, external vagal nerve stimulators are probably safe. But I think, again, it's going to be, challenging until we have specific data. Some of the other nerve stimulators, like the Cephali and the Relivion devices that stimulate the supraorbital and the supratrochlear nerves of the trigeminal nerve, as well as sometimes the occipital nerves, are probably also safe. There's a lot of data on TENS devices in pregnancy, sometimes TENS devices being even used on the stomach or on the pelvis. And so likely those devices are also safe. In terms of the TMS device, which is under the Inura brand, there is data on TMS in terms of depression in pregnancy. So that's a very different protocol, but there's some formulation of these devices have been used on pregnant patients. And so what we see at this point is that likely a lot of the devices are safe. Like Dr. Ilani said, except for the Rand and Nerivio device, we don't have any direct data, but at least from what we can tell, most likely the devices are all safe in pregnancy.
Thank you both. Maybe one last question. I think this one comes up a lot and is a really important one. So any concerns about general findings on acetaminophen, Tylenol, in pregnancy as a whole, since this is something that is commonly recommended to people?
So a few points about that. Many years ago, there was a couple of 2 or 3 epidemiology. So these are large group studies looking at populations as a whole, looking at acetaminophen, known as the brand Tylenol, for treatment of pain during pregnancy. And there was a association that those that were using Tylenol in pregnancy had children who developed ADHD later in life. The trouble with these large population-based studies was they didn't know why they were using Tylenol. They said it was for pain, but it could have been for anything. They didn't really have a good understanding of how much or how frequent, but it seemed to be often. There wasn't a clear understanding if there were other risk factors that might have been present for the children to develop ADHD. And the studies were so poor quality over time that the FDA just said these are not to be considered when you're looking at risk for use of this medication in pregnancy. When we look at what's recommended for treatment of migraine in pregnancy, the American ACOG, I always forget the
College of Obstetrics and Gynecologists.
Thank you.
That one?
I say ACOG and then I get to American and I forget the rest. So this is the Gynecological Association that makes their big recommendations. They recently published their recommendations of how to treat migraine in pregnancy. Their number one recommendation is acetaminophen or Tylenol. And so it's important to recognize that that is how safe they think the treatment is, that it made it to number one. And so I tell my patients, listen, there is absolutely nothing that is safe when you're pregnant, but neither is having a migraine attack. And so you really have to take the whole thing in perspective, that living and breathing isn't considered safe either. Being pregnant is not really a safe thing. So the whole picture is very important. And when we look at these large population survey type or just studies in general, there's lots of information and can get very tricky to really understand if the information that's out there is telling us much. And I just want to put out there my favorite little nugget of information on these types of studies was when my gynecologist was talking to me about caffeine and pregnancy. She told me, she's like, did you not know that those studies were done in women who are using cocaine and drinking caffeine at the same time? So you definitely can drink a cup of coffee every day when you're pregnant, probably two. And I just remember looking at her like, wait, what? And she's like, the level and the quality of these data points that we have on pregnant women are terrible because, again, nobody really does good quality studies on women who are pregnant. And so we have to be very careful with analyzing that information.
Very, very true. And we certainly need more studies in general. We are at time, but I'm just going to ask for the fastest 10-second take-home point from the night for each of you, please. Dr. Smirnoff, any last thoughts before we close?
I mean, I think my biggest takeaway is that when you're planning for pregnancy, working together with your team is so important. Advocating for yourself and making sure that your team knows how impactful your migraines are is going to make a huge difference in terms of your pregnancy.
Great. Dr. Ailani?
I think my fastest 10 seconds would be just to remember migraine is a disease. It's extremely disabling. Don't let someone make you feel like it's not. Advocate for yourself. And if you're having a hard time doing that, find a healthcare provider that is going to help you advocate for that disease. And that shouldn't stop you from living a full life.
Wonderful. That's great. And if you're still looking for resources to help with any of that, again, the American Migraine Foundation is here to try to help. Thank you so much to Drs. Ailani and Smirnoff for the great discussion. Thank you, everybody, for being here tonight. Please join us next month for our webinar on menopause, and we hope you have a great evening.
Bye, everyone.
Bye, everyone.